would like to just move on to immediately introducing our first and keynote speaker, whose name is Dr. Shasa Hu, who works at the University of Miami as a dermatologist. I probably don't know all the specific titles of various chairs of this or that committee that she holds, but I do know she's a very talented dermatologist who has a very nice field of research that she's going to tell us about and make it at a level that I think you guys are really going to enjoy and learn from. I would also just reiterate, if you have questions specifically about the presentations that will allow you to understand them better, don't hesitate to ask them. And then we'll have much more of a general sort of a free-for-all later on. So there should be plenty of time for interactions.
Good morning, everyone. Thank you so much for having me here today. It's really truly an honor and a privilege. I'm going to go right ahead to my talk. In the next 30 minutes, I'm hoping to share some of the facts about melanoma that you may not know. I'm sure everyone here, including those people joining us virtually, have already know a lot about melanoma through either personal experience or family experience. But today, I'm hoping to kind of enlighten everyone with facts that are important that may not be on your radar. I have no conflict of interest to disclose. And we're here today because melanoma is truly a huge public health issue as it continues to be among the top 10 new cancer diagnoses for both men and women in the US. And while the survival rate of melanoma has improved a little bit in the recent years, but we're still seeing a steady increase in melanoma incidence in the US as well as worldwide. This is why we're here today to talk about solutions, address gaps in care. And I'm hoping to share with you knowledge and research that we have done at University of Miami that may change what you already know about, for example, who gets melanoma, who's at higher risk of dying from melanoma, and lastly, is skin biopsy the best way to diagnose melanoma? Okay, so first question, who gets melanoma? Obviously, we already know a lot about melanoma risk factors, such as family history, such as your skin type, your sun sensitivity, and your sunburn exposure, as well as additional genetic factors such as DNA repair defects, certain genotype carriers. We also know that there are known genetic and modifiable environmental risk factors, such as how many sunburns have you gotten in the past, how much cumulative sun exposure you have gotten in your lifetime, where you live, and whether you have had tanning bed used, whether you have received immunosuppression for example, transplant, history of organ transplant. So those are known facts about melanoma risk factors. So when we think about who gets melanoma, we typically think of a light-skinned Caucasian person, such as celebrities we know, well-known, John McCain, Olympic swimmer Summer Sanders. But we also know that there are celebrities like Bob Marley, who actually passed away in my home institution, Jackson Memorial Hospital, from acral intentional melanoma. And more recently, former Miss Universe Stella Yara Torres got diagnosed with stage 3 melanoma from a mole that she neglected checking, and it changed over time. So really, not just white person got melanoma. Melanoma affects all skin colors. And I'm going to share with you a story that is not so common in my practice. And I'm hoping it's not something that you see daily here, but it reflects a issue that we're seeing in the world of melanoma. So this patient came to me. She was in her mid-40s. She was of Cuban descent, Hispanic woman, came to me of over 3 years of this, what she thought was a wart involving her fingertip. She initially sought care with her family physician, treated as a wart with a few sessions of freezing, did not get better. She got frustrated. She did not see anyone for a while and it got worse. And then she eventually saw a dermatologist in the community who thought, oh, maybe something else other than a wart. But unfortunately, the biopsy was not deep enough and did not really show much. And then so that was put aside. So, well, it was a wound and she got some wound care. And so not getting results from the medical system kind of led to not seeing anyone for a period of time. By the time she got to us was clearly a melanoma involving the digit. And of course, our biopsy confirmed that. And unfortunately, she did not do well. But so this is really a case illustrating delayed diagnosis, not being aware of who can get melanoma can potentially affect outcome. So really, when we look at who gets melanoma, yes, there are stratifications of risk factors as well as how much risk you have. So for example, while light-skinned Caucasians are at highest risk, Hispanics and Blacks also do get melanoma. And I'm going to spend a little bit more time about talking about melanoma in Hispanics because this is where we're seeing a emergent public health issue. So I want to back up a little bit just to kind of explain to you. Hispanic is really a self-identified ethnicity category. It really identifies people who originate from Spanish-speaking countries. So a person of Hispanic ethnicity can be of any race or heritage, from European, Native American to African. And we have a very diverse subgroups of Hispanics in the US, those from Mexico, those from Cuba, those from Puerto Rico, etc. So really Hispanic ethnicity encompasses a very heterogeneous group of populations with different skin color. They can be light skin color, they can have freckling, they can have sun sensitivity, or they can have a tanner skin, a browner skin. So really, Hispanic population is very diverse, but we also know that Hispanic population is among the fastest growing population in the US. It has been projected 1 every 4 Americans will be Hispanic by year 2050. And interestingly, over 50% of Hispanics live in just 3 states, where I'm from, Florida, here where you are, and Texas. And so this is why our group had the advantage of working closely with our state cancer registry and local hospitals to collect a lot of information to further examine melanoma in Hispanics. And we have found that melanoma incidence rates, while it's low in Hispanic, has been increasing steadily, particularly at an annual rate of 3.4% per year in Hispanic women. And that echoes to national data of 2.9% per year increase in Hispanics. And that is really comparable to 3% increase per year in non-Hispanic whites. Not only that, we have reported that Hispanics have delayed melanoma diagnosis and they have worse outcome. When we looked at Florida State Cancer Registry, it was found that a significantly higher proportion of melanomas diagnosed in Hispanics were at distant stage at time of diagnosis compared to non-Hispanics whites. And when people looked at the National Cancer Registry, SEER, surveillance, epidemiology, and end results that collects information from major states in the US, and this group looked at over 30 years of data, again, found that there's a significant disparity in late-stage melanoma diagnosis among skin of color communities. And additionally, even in the local life stage, skin of color patients are more likely to have ulcerated melanoma with greater depth. And this is an issue because we all know melanoma survival is intimately related to stage diagnosis. And it has been confirmed when you look at this graph, whites definitely have the best survival rate from melanoma, and skin of color patients have worse survival rate. Again, I just want to reiterate the poor outcome likely is due to later stage diagnosis. This study, using the same 30-year interval data from SEER registry, found additionally not having as good of a survival rate, skin of color patients have not experienced improvement in melanoma survival in the past 20 years. And when you compare survival rate before 2000, 2009 to those diagnosed after 2010. Interestingly, in patients with regional and distant stage, only Hispanic individuals have actually had worsening survival rate in melanoma specific survival rate. And this is really interesting to note and important to try to understand better, because we know that, as I show you very beginning of the talk, melanoma overall survival rate has improved due to the introduction of immunotherapy and target therapy, but clearly non-white populations, including Hispanics, have not really benefited from the introduction of these more effective therapies. And in fact, studies have shown that skin of color patients are less likely to enroll in clinical trials and receive immunotherapy. So our group wanted to delve a little bit further to examine what factors may contribute to this differences or gap in melanoma outcome. Obviously, the two biggest factors impact melanoma outcome are race, ethnicity, and socioeconomic status, which is really how affluent, how poor you are. In the past, studies have been limited, not able to tease out the difference between race, ethnicity, and socioeconomic status, because these are two intimately related factors. So our group did a study using area-based measure to kind of really see if there are independent risk factors or they are dependent risk factors when it comes to melanoma outcome. So using an area-based measure is a very neat and also validated research tool. Basically, instead of getting your salary information, getting your tax returns from every individual melanoma patients, we look at where the melanoma patients live. The idea is that where you live influence or is a reflection of how well you do economically. So if you live in a poor, low-income urban neighborhood, it's very likely that you also have a lower income. And versus if you live in a more affluent neighborhood, it's more likely that you have more resources, financial resources. So in this study, we identify clusters of late-stage melanoma in Florida, and within each clusters, we examined race, ethnicity, gender, insurance status, as well as poverty and socioeconomic status based on where people live. And we found that poverty clearly was an independent risk factor. For every 1% decrease, when you have poverty below the poverty line, you have a 2% higher risk of getting late-stage melanoma. Male have a little bit worse risk factor, but the strongest predictor for late-stage melanoma was being a Hispanic person, and that's independent of insurance status as well as gender and poverty. So our study validated this concept that Hispanic ethnicity is an independent risk factor for late-stage melanoma, and it outweighed other factors we know already impact melanoma outcome. And so this is very puzzling. Why? What's going on? Is it because they have different tumors, or is it because we are seeing cumulative effects of barriers to health and also individual level issues such as awareness and knowledge? So we wanted to look a little bit deeper. We looked at individual level knowledge, awareness, and behavior and attitude towards skin cancer and melanoma prevention in Hispanic population, and found, yes, Hispanics have less knowledge about skin cancer, and this affects their behavior. And I think this is not just unique to Hispanic population. If you substitute Hispanics with Blacks or with Asian Americans or with even non-Hispanic whites, but at lower socioeconomic status, I think this holds true. Knowledge correlates behavior. We found that Hispanic patients are much less likely to use sunscreen or wear protective clothing. We also surveyed high school students in Miami. We wanted to look at the youth because, as we know, that a majority of our sun exposure lifetime occurs when we're younger, especially young adults. And we found that after controlling for their skin type, their family history, their sun sensitivity, Hispanic students compared to their non-Hispanic white peers, so these are groups controlled for the differences in skin color and sun sensitivity, are much more likely to have used tanning bed, a lot less likely to use sunscreen, think of themselves as less likely to have skin cancer, and have also a lot less knowledge about skin checks and never had been told how to check their skin. So that's important. There's definitely a gap that we need to fill when it comes to educating Hispanic population. We also looked at secondary prevention, that is getting skin cancer screening, getting skin checks. It was found that Hispanic patients are a lot less likely to have had a full body skin check by the primary care physician compared to non-Hispanic whites. And this has been confirmed with other study looking at Hispanics elsewhere in the country as well. And now, of course, in addition to what you know about skin cancer, in addition to your genetic background, race, ethnicity, there's also system factors. So system factors are factors like what kind of insurance you have, what kind of plans you have, how do you access healthcare, how much do you access, how well do you know about navigating the healthcare system. So typically when we look at healthcare system, there are either fee-for-service or managed care in the US. These are the two main types of healthcare delivery system. So our group have found that when we looked at Medicare patients, so those are patients older than 65, it's interesting that Hispanics enrolled in Medicare fee-for-service are much more likely to receive late-stage melanoma diagnosis compared to Hispanics enrolled in HMO. And then within the fee-for-service system, Hispanic Medicare patients were also a lot more likely than non-Hispanic whites to have late stage and also have less survival rate. So this, again, points out to an issue that's maybe inherent to how Hispanic patients navigate fee-for-service. So definitely needs further investigation. And then when we look at the last element, which is tertiary prevention, which is at the step after you have received a diagnosis of melanoma, what occurs after that diagnosis. Studies have found that skin of color patients are much more likely to have a longer wait time from diagnosis to definitive surgery. And Medicare and Medicaid patients also have a slightly longer wait time. And then additionally, skin of color patients are much less likely to receive immunotherapy or enroll in clinical trials. So those are, again, identifying gaps where we could improve and close the gap, improve outcome for melanoma. So when it comes to who gets melanoma, I'm hoping that I have convinced you that everyone can get melanoma. But even though Hispanics and Blacks have lower risk, they're at higher risk for being diagnosed with more advanced disease. And this is why when we ask the question, who is at high risk of dying from melanoma, when we look at the global data, taking a whole, Hispanics and other skin color communities have worse survival rate and have not benefited so much of the advances that we have seen lately in immunotherapy and target therapy. But there is hope. I have presented gaps in our care. And so really, if we work together, we can potentially definitely improve and avoid cases that I'm seeing in the clinic, such as late-stage acroneogenesis melanoma that have metastasized at time of diagnosis. And just very briefly, as providers, we should really be aware of how to give a culturally competent encounter. So taking the account of patient's knowledge level, linguistic preference, what the culture background is, how do they think about skin cancer, what's their attitude towards the diagnosis. We also need to have improved community outreach programs to really educate minority populations patients, especially Hispanic population, as it will not be minority in a few years. And then lastly, we also need to improve awareness on providers on how to triage patients with skin of a color background, and also look at the gaps where the healthcare delivery system is failing certain patient population. Now, I'm going to move on to the last part of my talk, that's changing gear. So stepping away from the public health aspects of melanoma, I'm going to share something that you may have not heard before. You may have, but the question is skin biopsy the best way to diagnose melanoma? Of course, skin biopsy continues to be the gold standard because it gives us histology, it gives us depth, it gives us tumor histology in terms of ulceration, mitosis. However, there are some limitations of skin biopsy, especially sometimes we don't get the best sample. Sometimes patients may have lesions on very cosmetic sensitive areas where you may want to think twice about risk of biopsying something that's ended up to be benign. And also we have high-risk melanoma patients who have hundreds of dysplastic nevi. Do we really want to cut out all the nevi because we're suspicious? And additionally, biopsies leave scar, and a lot of times areas that, for example, if you look at my patient with dysplastic nevus, I'm going to move this panel slightly. I'm going to hide this, I'm sorry. It's impossible to know what you're going to biopsy, what's going to give you the best yield. So in our institution, we use a variety of tools. We have dermoscopy, where it's a kind of like a fancy magnifying lens that let us to see structures and cells and light reflection at deeper, greater depth. That helps us to be more accurate in terms of our categorization of a lesion. We also use short-term digital monitoring. So we look at a mole. If it looks strange, what we call the ugly duckling sign, or funny looking mole, we follow them instead of jumping right ahead into biopsy. This is a lesion on my patient's back. It looked weird. It had like some irregular globules. And we did a short-term monitoring in 6 weeks, in 12 weeks. As you can see, these little dots have changed over the course of 2 intervals of 6-week monitoring, and with biopsy, it was a evolving melanoma. That really helped us to justify the biopsy. Sometimes we use total body photography or mole mapping. This is this is actually a screenshot of a computer projection of my patient with dysplastic nevus syndrome. So as you can see, comparing photos taken a year apart, this is a brand new nevus or new lesion, even though it looked harmless on dermoscopy, because it's brand new on an adult. So adults usually should not have new moles. With biopsy, it was a atypical Spitz nevus, and that helped us to diagnose and catch it early, so to speak. But sometimes these are not enough. So I'm going to talk to you about something that we use in our clinic. It's called reflectance confocal microscopy, RCM. Have you guys heard of it? Confocal microscopy for skin diagnosis. I see my colleague who is also a speaker today have seen about it, but it's not something so common. It's only in certain cancer institutions. So this is a non-invasive tool that allows us to visualize cellular structures without taking a sample of the skin. Of course, there are some limitations, but really when you look at this technology, it gives us a way, it's almost like ultrasound of the skin, but we're able to see cellular structures because of the reflective property of especially melanocytes. So we definitely use this as an adjunct tool when we evaluate high-risk melanoma patients. So this is the machine, what it looks like. When we have something suspicious, we use a ring that attached to the skin. It has a sticky on this underside. And this is all my research fellows. we then kind of place the laser head and then kind of attach to the ring, and allows us to scan this lesion of interest at different level of depth. I'm going to show you very quickly. How am I doing on time? Okay, sorry. There's no clock here, so I wasn't sure. Okay, it won't take too long, but I think this may be fun for everyone to see. For example, so this is like a cartoon of what the top layers of the skin look like. And so using confocal, if we scan at the very superficial level, which is called stratum spinous, spinonosis, so and you can see this is what the skin looks like under the RCM or confocal microscope. This is a very nice, what we call a normal honeycomb pattern of healthy or normal skin. You can see these are keratinocytes at the spinous layer. But if we scan a little bit deeper, where the epidermis meets the dermis, so this is important. And when we talk about melanoma, anything invades the DE junction with the dermal epidermal junction is really invasive. And melanoma, and that also the deeper it goes and the higher the Breslow depth. But at the DE junction, if we say take a en bloc cross section of skin, so you can catch the undulating hills and valleys of the DE junction. And this confocal, it gives us exactly that. So the dark, round, oval areas represents the dermal papillae, and they are circumscribed by these little rim of bright cells. These bright cells are typically your melanocytes at the basal layer, or melanin-containing keratinocytes reflecting kind of the basal hyperpigmentation. So this is what a healthy DE junction looks like, what we call dermal, I'm sorry, I'm gonna go back. Healthy DE junction is called edged papillae. So this is what good looks like. And we go a little bit deeper, scanning at the superficial dermis area. So now we're below the epidermis. You can see, I mean, I don't think you need a medical degree to know this looks good. This does not look good. So these are sort of the ugly, atypical, very heterogeneous, bad melanoma cells on confocal. As you can see, the confocal really gives a great detail of what cells look like, their configuration, and how large the cells are, how uniform they are, without the need to biopsy. So I'm going to do a couple cases, just kind of illustrate the role of confocal microscopy in a clinical setting that may be more of interest to melanoma patients. This is a patient I took care of a few years ago, actually like 6 or 8 years ago. He came to me, he's from Honduras. Obviously, even though he's Hispanic, but he's light-skinned Hispanic, he noticed this growing dark, what he called like a sunspot over like a few years. And he was seen by a few dermatologists. No one really wants to take a big chunk of skin off someone's nose. So he had a few biopsies were not conclusive. So they're sunspot, not sunspot, like what we call like lichen planus, like keratosis, but he just did not feel right because it kept changing, kept growing. So when we looked at using just the typical dermatoscope, which is like a handheld magnifying lens, fancy handheld magnifying, you can see there's a scar from prior biopsy, but you can see here some irregular sized follicular openings right next to the scar. So that is kind of suspicious, but did not really scream out melanoma. This is what another photo taken with the confocal, the macroscopic head of the confocal. So we took a scanning of what we thought looked most asymmetrical area on the lesion. As you can see, I will zoom in these areas a little bit later. This is not the spinous layers. You can see these are areas we have sheets of dendritic cells. They're kind of elongated, kind of wavy, bright cells. And when we zoom in a little bit more into these little sheets where area have the sheets of dendritic cells, so these are the bright lines, squiggly lines, but you also have what we call patch toy cells, which is not something we should see in healthy skin. And And when we looked a little bit deeper at the non-edge, at the D junction, this is not a typical oval, round with ringed edges. This is called non-edge papillae. And we also found dermal nests of atypical cell around the sebaceous gland. So this is something more for clinicians. So that means we should not be treating with a topical chemotherapy because it went down the sebaceous gland. So this confocal, the diagnosis was melanoma, and a biopsy confirmed by using the confocal guiding us where the worst area looked like. So this gentleman had a full resection with skin graft. This is him 5 years later. You can see the scar has healed very nicely, barely noticeable, and I'm still seeing him. He's doing great. But this is a case where confocal really help us to narrow down the diagnosis. The second case is also interesting. This is a male with history of melanoma, skin cancer, new facial lesion. It looked like nothing. It's like 1 millimeter. Are we going to biopsy this? On dermoscopy, it shows some gray dots. It could be pigmented BCC, it could be LPLK, but would you biopsy a big chunk of someone's face when you're not sure? So this is where we bring the confocal in. On confocal, you see there are some bright cells with atypical pattern. Again, when we look at the D junction, this is very atypical non-edge papillae. You can already see the atypical cells here. And I'm just going to show you, we can follow areas. I'm going to go through like almost like a picture. You can follow the enlargement, the atypical cells going through the spinous, going down to the D junction. So on confocal, you really look at melanoma. So that when we decide to biopsy it, and then it turned out to be a melanoma in situ. Last case, this lady was referred by her rheumatologist for a suspicious mole on her right calf. She has no family history of melanoma or skin cancer, really very minimal risk factor. It looked a little bit suspicious. On dermoscopy, it looked very vascular, like a lesion, like a blood vessel lesion, but with some atypical scar-like areas. So it's not clear 100%. When we use confocal, you can see first scanning, the structure kind of matches what it looks like clinically on dermoscopy. And when we looked at the dark areas, it turns out to be blood vessel. And so using confocal, we're able to get additional reassurance that these are just lacunae of like a dilated blood vessel. So this is a capillary hemangioma. We don't even need to biopsy. When you say this is not worrisome, no, leave it alone. But we also did a full body skin check. So this is where we call the incidental finding, where patients comes with something suspicious, we call the index lesion, but often skin cancer is the incidental finding. And we found this on her thigh. On dermoscopy, it's a little bit suspicious, but not screaming melanoma. You have granules, you have dots, you have some reticular network. And so it's like, should we cut it out? Should we monitor it? So on we did a confocal, and you can see on confocal, this does not look good. You don't have the typical honeycomb pattern. You have dendritic cells. You can have these large pagetoid cells. And if we keep going, this is again showing areas you have large atypical cells. And again, you get the idea. So at D junction, we even saw nucleated cells with atypia. And so these are not supposed to be on normal benign lesions. Again, just multiple areas of bad looking stuff. And so dermoscopy diagnosis, we had dysplastic nevus or melanoma, confocal diagnosis, melanoma, and it turns out to be a early superficial spreading point to find melanoma. So in summary, I have shown confocal actually is a very useful tool. Skin biopsy is the ultimate gold standard, but we have non-invasive tools to help us to better manage, triage suspicious lesions, especially in patients with high-risk melanoma, also dysplastic nevus syndrome. Of course, this is a limited technology. It's expensive, it requires specialized training, and it's not for everyone. But to answer the question, is skin biopsy the best way? It's still gold standard, but we can do better. And there's definitely evolving technologies that we'll make share with you at a different conference about non-invasive diagnosis of melanoma. So this concludes my talk. I hope I have brought some new information to everyone. Again, thank you so much for having me. Stop sharing.
Sure. Well, thank you so much. I know for the audience, this raises a lot of questions, certainly from a patient standpoint of how we take care of you, how do we make the diagnosis? Some of the technology that has been shown is evolving. There are other methods that are being worked on, including like, I know myself, we say, what about the apps that are available for the patients? But anyway, we could talk about that later as we move along. So if there's any pressing questions, we can have them now. Otherwise, we'll wait to the end and we'll move ahead.